13, which is the cardiovascular system. Actually, 13 and 14 are both the cardiovascular system, but 13 is focused mostly on the heart. Now, as an overview, the cardiovascular system is the heart. What does the heart do? It does one job. One job. It pumps blood. It's the engine. It's the engine that is pumping blood, and blood is the transportation mode. And so when we look at blood, is the transportation mode in our body for distance travel. Why distance travel? Well, we have diffusion for, short little jaunts, but blood is really the transportation mechanism for distributing things throughout our whole body. And this blood travels in vessels, arteries, and veins. Capillaries are where things are exchanged between the blood and interstitial fluid or tissues. So we have the heart, we have blood vessels, we have blood. And we're going to talk about blood in lab. So we kind of cover blood in lab. And so really 13 is the heart and 14 is vessels in the circulatory system. So that's the way it's broken down. The cardiovascular system, it says it's impacted by the endocrine system, nervous system, and the kidneys. And we're going to get into this when we talk about heart rate, blood pressure. These are all things that are controlled by the endocrine system and nervous system because these are the chemical messengers. And chemical messengers, if you remember, message other organs and cells to do stuff. So in this case, it's telling the heart to do stuff or the blood vessels to do stuff. Kidneys control blood volume. And blood volume ultimately controls blood pressure. So we'll talk about that in 14. Overview of the cardiovascular system. Hopefully you remember your anatomy. If not, you have the YouTube lectures for heart and cardiovascular system and even blood anatomy. And those are chapters 20, 21, and 22. So if you want to review your anatomy, chapters 20, 21, 22 is going through blood, the heart, and the cardiovascular system. I'm not here to teach you anatomy. Supposedly you've done that. So as an overview, I'm going to really breeze through this. And if you want to go back because maybe it's been some time since you had anatomy or you want a refresher, check on the YouTube videos. All right. The heart is a muscular pump, and that muscular pump has 4 chambers, 2 atria up top, 2 ventricles down below, right and the left atria, right and the left ventricle. And so we have one heart, but it pumps blood to 2 separate circuits at the same time. That's important to remember. So you have the pulmonary circuit and you have the systemic circuit. And if you can't remember those, review, my friend, review. There's a third circuit, the coronary circuit. This supplies blood to the heart muscle, which is really important. So your coronary vessels are actually bringing oxygen and nutrients to your heart muscle cells or cardiomyocytes. They need oxygen and nutrients to stay alive. So those coronary vessels and that coronary blood and that coronary circulation is really, really, really important. A heart attack or a myocardial infarction, that is when a coronary vessel is blocked and cannot distribute oxygen and nutrients to the heart cells downstream. And so those heart muscle cells will die. We call it a heart attack or a myocardial infarction. So the coronary circuit, coronary arteries, really important. Coronary artery disease, bad. And we'll talk about why. The heart is a pump. It pumps blood. And we're really going to get into cardiac output. Cardiac output is a measurement of blood flow. Flow meaning how much volume is moving in a given period of time. So cardiac output is the volume of blood moved or pumped by the heart in 1 minute time. So that's your cardiac output. We'll get real in depth about that. All right, the heart is a muscular pump. That means it has a lot of muscle, and that muscle is called the myocardium or muscle layer. There is an outer layer. Hopefully you remember that outer layer. That is the visceral pericardium. It's the serous membrane that is attached to the outside of the heart muscle or myocardium. And then there is actually an inner epithelial layer called the endocardium or cardiac layer, and it's lining the inside of the chambers, heart chambers. And when I say chambers, the atria and the ventricles, the endocardium makes up the heart valves. Then you're going to have this little space here. You can see this space. This is your pericardial cavity or space. It's a little fuzzy, but you can kind of see that pericardial cavity or space. And then this outer membrane here, this would be the parietal pericardium, that serous membrane on the outside. Now, the visceral pericardium has another name because it's on top of the myocardium. And when things are on top, we say epi. So it's the epicardium. So you have the epicardial layer that's on the outside. And then you have the endocardial layer, which is lining the inside of the chambers. So this really goes over the epicardium. And the epicardium is the visceral pericardium. There's the pericardial space or cavity. And then there's a second membrane on the outside, which is the parietal pericardium. The myocardium, that is cardiac muscle tissue. They are myocardiocytes or muscle cells. And then you have the inner endocardium, simple squamous epithelium. It's the inner surface, including the valves. So when we talk about the AV valves or the semilunar valves, that is endocardium as well. All right, heart anatomy. Review. I expect you to know all these structures because I'm going to talk about them. So if you want to review that, you can pause me now and then go to the YouTube site, check out chapter 21 in anatomy playlist and go through and review your heart anatomy. Same goes for the posterior surface. So you have the anterior surface. I'm going to talk about the great vessels. You've got superior vena cava, inferior vena cava, aorta, right, brachiocephalic trunk, left and right common carotids, left subclavian, pulmonary trunk and right and left pulmonary arteries, right and left ventricles, and so forth. Backside, you're going to see pulmonary veins. Remember, they are red because coming from the lungs with O2 loaded up. So pulmonary arteries are blue because it's deoxygenated blood. And pulmonary veins are going to be red because it's oxygenated blood. These are veins. That's the superior vena cava and the inferior vena cava. That's returning blood. All right, on the inside, we will be talking a lot about chambers and valves. So everything above the diaphragm, all the venous blood returning to the right atrium via the superior vena cava, and below the diaphragm, venous blood is returning through the inferior vena cava to the right atria. Now, from the right atria, blood is flowing down through the right AV valve. And so I'm going to highlight that for you. This is the right AV valve, this valve right here. And there are these little cords that attach that valve to an inner muscle here. And that muscle is called the papillary muscle. Papillary muscles hold the chordae tendineae shut when the heart's contracting. So the AV valves stay shut when the heart is contracting. This also is the same for the chordae tendineae on the left AV valve. And they as well have pulmonary muscles that are attached that hold the left AV valve shut. So this is left AV valve. So you have a right AV valve and a left AV valve. By the way, A is for atria, V is for ventricle. It is the valve that closes off the atria from the ventricles when the heart is contracting. There are two other valves we will be talking about. They are the pulmonary semilunar valves, which is this right here. And then up in here is the aortic semilunar valve. These two valves are going to open when the heart's contracting and then close when the heart is filling up with blood or resting. So they are the valves between the ventricles and the arteries that are attached to the ventricles. So the arteries that are attached to the ventricles, this is the pulmonary trunk, and it is the main artery taking blood from the right side to the lungs and then back to the left atrium. The aorta is the main artery for the systemic circuit. So bringing blood to all the cells of the body. That is, you have the aortic semilunar valve that's going to go from left ventricle to the aorta. Also review pulmonary circuit, where's the blood flowing, systemic circuit, where's the blood flowing, and coronary circuit, where's the blood flowing. And this diagram shows you nicely, you have the right side and you have the left side. From the right side, you have venous blood returning to the right atria, filling the right ventricle, going up the pulmonary trunk, and then left and right pulmonary arteries. They're going to return blood back to the left side, newly oxygenated. That's the pulmonary circuit. Systemic circuit takes the newly oxygenated blood, sends it up the aorta to all the cells of the body, whether it's up or down, all the way to the capillaries where there can be exchange of nutrients. And then that venous blood is going to return back to the right side. So you have these circuits going on. Serious flow through the cardiovascular system is basically describing what I just went over, which is it's the path of blood flow. And the cardiovascular system is a closed system. These vessels start at the heart and they end at the heart. So this is simplifying it. This right here would be the pulmonary semilunar valve. And this right here would be the aortic semilunar valve, right? So you have these two valves. And the heart contracts and it pumps blood to the pulmonary circuit, to the pulmonary capillaries where there's exchange of gases, and then the pulmonary veins back to the heart. It's not open. There is exchange of nutrients here at the capillary level, but then those capillaries merge and become veins and brings the blood back to the heart. Same thing in the systemic circuit. You have blood newly oxygenated leaving from the left side out the aortic semilunar valve, traveling to all areas of the body to where there are systemic capillaries. And at the level of the systemic capillaries, there's going to be exchange of gases and nutrients. So the blood's traveling. Then those vessels just start to merge, and we call it veins because veins return blood back to the heart. Still a closed circuit. So at a minimum, I really want you guys to review the circuits, flow through the systemic and pulmonary circuit. So if it's going from the left ventricle, this is blood flow, by the way, to the aorta, it's the systemic circuit, right? And it's going to go all the way, these should be arrows, to the systemic circuit and returning blood to the vena cava, the great veins, which sends blood to the right atrium and then sends it to the right ventricle, which then sends it to the pulmonary circuit. And it's going to then go to the lungs through that pulmonary circuit and then return to heart via the pulmonary veins and to the left atrium and then down to the left ventricle, and we kind of start all over again. So it's this systematic blood flow. And there's a couple of things you need to understand, that the right and left ventricles are pumping equal volumes of blood at the same time. So half is going to the pulmonary circuit to the lungs, and the other half of that blood is going to the systemic circuit or all the cells of the body. Same volume, but the pulmonary circuit is shorter, less distance to travel, lungs are right next door, and so the blood flow is a low pressure system. So the flow rate has to equal the flow rate of the high pressure system in the systemic circuit because you have a lot longer to travel to get blood all the way up to the top of your head, down to your toes, back to the heart. So the systemic circuit has a higher pressure because the flow rate still has to remain the same because that blood has to kind of travel at the same speed, so to speak, so to make it back to the heart at the same time. So these two circuits can be synced up. Then there's a coronary circulation. Super important. Heart muscle cells die if they do not have oxygen and nutrients. So the coronary circulation brings these oxygen and nutrients to the heart muscle cells. And heart muscle cells are aerobic cells. They require oxygen to produce ATP, and they need ATP in order to contract and to do active transport and sodium potassium pump and generate electrical impulses. And so if they're lacking in oxygen, they can't produce ATP, they can't actively transport. Sodium comes in and is not being pumped out. Water follows sodium, cell blows up, explodes, cell dies. So that's what we call a heart attack. So coronary circulation is really important. We have a right coronary artery and a left coronary artery. And the left coronary artery really services the left side, and the right coronary artery services the right side. Then those arteries become capillaries and merge back into veins. And so we kind of have a small, medium, and large vein, bringing blood back to the right atrium. So this is the coronary circuit. And this is kind of a cool picture because, well, I don't know if it's cool for the person, but if you have a blockage, they're doing an angiogram and they're threading some kind of camera up through the femoral artery. They're checking out all the coronary vessels. And they can start to see areas where there's blockage because they put a radioactive dye in, and they can see where there's less blood flow. And so you can see that there are blocked coronary arteries. There's less blood going through those coronary arteries. So angiograms are helpful in diagnosing coronary artery disease. That is when people start to have procedures getting blood, stents in their coronary arteries that kind of expand the artery. A lot of times they'll have to go to coronary bypass surgery, which is an open heart surgery because coronary vessels are really small and we can't really get stents in there as well. And so that would be the next level, is coronary bypass surgery. So parallel blood flow within the systemic and pulmonary circuit means, if we're looking at the pulmonary circuit, right? So this is pulmonary up here. It means the right and left lung both receive blood at the same time. That also is true for the systemic. So this is systemic blood flow. And you can see from the left side of the heart, the brain's receiving blood at the same time the heart's receiving blood, coronary circuit. At the same time, small, large intestines, stomach, gallbladder, kidneys, spleen. Kidneys. I should have said liver. I meant to say liver. That's the gastrointestinal tract. That's the celiac trunk. And the superior and inferior mesenteric arteries. And then you have kidneys, and you have muscles, and you have skin, and you have other tissues, and they're all receiving blood at the same time. That blood's going to go through capillary networks, and then those vessels are going to merge, and we just call them veins because the definition of vein is vessels that bring blood back to the heart. And this is all going on at the same time, so we say it's parallel, right? So you have parallel blood flow. By the way, the aorta branches into smaller arteries, which then branch into smaller arterioles, which then branch into capillary beds. Then you have merging. And so here's where we pick up down here. Capillaries merge to become veins. That means that multiple vessels are coming together to form a bigger vessel. They're merging. And then smaller veins merge to become bigger veins. And eventually, all the veins are going to merge either into the superior vena cava or inferior vena cava. So that's that blood vessel and flow, right? So we have the heart pumps blood to the big arteries, which then branch to get smaller arterioles, which branch to get smaller capillaries, which then merge. So again, arteries branch, they separate into multiple, then they merge, then they merge. And so it is a closed circuit. So the vasculature, here's the definition of arteries, arterioles, and capillaries, and you can look at those. All right, heart valves, really important when we're talking about the cardiac cycle. Heart valves prevent blood from going in the wrong direction. Heart valves ensure unidirectional blood flow. They ensure that blood only flows in one direction, right? Moves forward, not backwards. Backwards would be bad. And so, atrioventricular valves. These are the valves between the atria and ventricles. They prevent backflow of blood into the atria when the ventricle is contracting. So there is the right AV valve, also called the tricuspid. There is the left AV valve, which is also called the bicuspid or mitral valve. You can call them any of the names you want. The right AV valve, left AV valve have chordae tendineae anchored to papillary muscles. And those papillary muscles contract when ventricle contracts. And so these papillary muscles contract when the ventricle contracts. And what do? They hold AV valves closed during systole. Systole is when the heart is contracting. Same thing. So the AV valves, they are between the atria and the ventricle. They are anchored by chordae tendineae to papillary muscles, which papillary muscles contract when the rest of the ventricle contracts, holding the AV valve shut. So blood only goes out the semilunar valves. Semilunar valves are between the ventricles and either the pulmonary trunk for the pulmonary circuit or the aorta for the systemic circuit. So you have the pulmonary semilunar valve and the aortic semilunar valve. They prevent backflow into the ventricles when the ventricles are relaxed or in diastole. So when the heart's contracting, are the AV valves open or closed? If you said open, you'd be correct. They are not closed. If they were closed, no blood can go into the pulmonary trunk or the aorta, so there would be no blood flow. So they are opened during ventricular contraction or systole. Systole is when the heart's contracting. Diastole is when the heart is relaxing. And so you can see here you have the right, I should probably do it in another color, right? The right AV valve and the left AV valve. Then you have the aortic semilunar valve and the pulmonary semilunar valve. Pulmonary trunk is anterior to the aorta. Now, heart valves, like I said, when blood is returning to the heart, it's passively filling the atria. Atrium is singular. And then that blood forces the AV valves open, and the blood then passively fills down into the ventricle. There's the blood in the left ventricle. Okay. So when the AV valves are open, atrial pressure is greater than ventricular pressure. And what does that do? Oops, I didn't mean to do that. Keeps AV valves open. So when atrial pressure is greater than ventricular pressure due to blood filling ventricles, well, I should say atria and ventricles, it's keeping those AV valves open. It's putting pressure on the AV valves so they stay open and blood is flowing into the ventricle. This is during diastole or relax ventricle. Ventricles relaxing, blood's pushing on those AV valves, adding pressure, keeping them open. So AV valves are open. But ventricles start to contract. Papillary muscles also contract, pull on the chordae tendineae to hold the AV valves closed. And so capillary muscles contract the chordae tendineae pulling. They prevent the valve flaps from opening. So blood only goes this direction. And then eventually, when enough pressure is created by the heart muscle contracting, that pressure is going to increase and push open the semilunar valves. So as the ventricles contract, the so inside pressure of the AV valves being closed and the muscle contracting, the pressure gets so high in the ventricles that it forces the semilunar valves open. And so it's going to push open those semilunar valves while the muscle's contracting and eject the blood one direction out the pulmonary trunk and the aorta. This is during systole. Wow, can't spell, can I? This is during ventricular contraction. And then eventually the pressure drops because there's no blood. It got pumped out. There's a little bit of blood, but this picture shows no blood. And that's a drop in pressure. So big drop in pressure. And so as the ventricles relax, the intraventricular pressure, the pressure inside the ventricles, drops. And so the semilunar valves close. So blood flows back onto those semilunar valves. There's no pressure to keep them open because there's no blood getting ejected from the ventricles. And so those semilunar valves close. And that would complete one heartbeat, right? Your heart filled up with blood, it contracted, ejected that blood out, and then it's going to start over again. That's really what a heartbeat is, or a cardiac cycle. And so the sounds we hear with that, you know, when you hear your heartbeat, it goes like boom, 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 boom. That's the valves closing. So the two sounds that we hear are the heart sounds, or the valves closing. And so the first sound is when the AV valves close. That's always going to be at the beginning of systole or ventricular contraction, followed by blood ejection. Then eventually after the blood's ejected, you're going to hear the second sound, which is the semilunar valves closing at the beginning of ventricular diastole or relaxation of ventricle. Now you know the heart's going to start filling up with blood again. So one heartbeat is boom, boom. AV valves closing. You don't hear the heart contracting and pushing blood out, but you do hear the semilunar valves close. Stethoscopes, when they're put up to the chest, are very specific. So upper right would be the aortic semilunar valve. Left would be the pulmonary semilunar valve. Lower right would be the right AV valve. Lower left would be the left AV valve. And so primary care physicians or PAs or nurse practitioners, nurses, they're putting that stethoscope to specific areas to hear your valve close, and then they listen for silence. Because if blood is going the wrong direction back through a closed or mostly closed valve, you're going to hear a little murmur or whistle because fluid is eking through what should be completely closed, but it's eking through there and it's causing a little sound. And so we call that a heart murmur. So heart murmurs are when the valves are allowing blood to squeeze back up through them. So the most common is usually a heart murmur in the mitral valve. They hear a little murmur, a little sound, but practitioners are trained to listen to each valve independently to see, make sure that all valves are closing and that you don't hear anything after. Cardiac muscle tissue are actually called myocardiocytes, right? Because it's heart muscle or cardiomyocytes. This would be cardiac. This would be muscle. And this means cell. So cardiomyocytes. Cardiomyocytes are like skeletal muscles. There's actin, there's myosin, they have sarcomeres. The main difference is that they are connected to one another. And so they're connected to one another with gap junctions that allow the sodium and potassium electrons to flow from one cell to the next. So one heart muscle cell depolarizes, forms an action potential, and those ions flow to the next. And then these heart muscle cells or cardiomyocytes are connected via these intercalated discs. So you can see here, here's the gap junction that's allowing the ions to flow from one cell to another. And then you have the intercalated disc connecting the two cells together. One very important fact is that cardiomyocytes rely exclusively on aerobic respiration, which means heart muscle cells require oxygen all the time. There is no anaerobic glycolysis. They cannot just do anaerobic glycolysis. They have to have a steady stream of oxygen to efficiently transfer the energy from nutrient sources like glucose and triglycerides to ATP. Another difference is that there is more vasculature or capillaries because of the fact that they need oxygen. And cardiac muscle is controlled by the autonomic nervous system, unlike skeletal muscles. So these gap junctions, intercalated discs, help spread the excitation, right? Another way of saying spread the action potential or electrical impulse from one cell to the next. So they go in a synchronous order. It'll be the cells of the atria contracting first, then the ventricles contracting second, and there's coordination. And this is due to the gap junctions where ions can flow and the intercalated discs connecting those cardiomyocytes together. And so they're showing you the sarcomeres, they're like skeletal muscles. There are nodal cells in the right atria that spontaneously depolarize. And so they can generate electrical impulses all on their own without any other neuron telling them to. They are innervated by sympathetic neurons and parasympathetic neurons, but they don't need to be told what to do by the autonomic nervous system. They can start depolarizing all on their own on a regular pattern. And so the SA node stands for sinoatrial node because it's in the atria. And they set what's called your sinus rhythm, which is your resting heart rate. It's an H. So the SA node is going to spontaneously create action potentials that then go over to the left atrium and travel down to the AV node, which is the atrial ventricular node. Right, so A for atrial, V for ventricular. Then from there, they generate electrical impulses down what used to be called the bundle of His, but now it's just the bundle branches, which then separate into a left and a right bundle branch. So this is how the wave of depolarization flows. It's going from the SA node over to the left atria to the AB node. There's a pause, the atrias contract because contraction follows depolarization. It's going to make that muscle cells contract. So as that electrical current contracts, we talked about this in the chapter 11, the autonomic nervous system, as well as the somatic nervous system. Depolarization of these cells creating an action potential is going to create action potentials in the cardiomyocytes, which then releases calcium out, and calcium binds to troponin, tropomyosin moves, and myosin heads can reach across, form cross bridges, and start contracting, right? So you need that electrical impulse to then generate the electrical impulse in the cardiomyocytes. So contraction follows the electrical impulse moving through the electrical system of the heart. And so then it's going to flow down the interventricular septum to the right side down to the apex and up, down the interventricular septum, the left side to the apex. This, by the way, is the apex. And then up the sidewalls, as well as these Purkinje fibers that go into the myocardium, as well as the papillary muscles. So this is how the papillary muscles are told to contract and pull and keep those AV valves shut. So the wave of depolarization is kind of cruising down the interventricular septum and then up the sidewalls. So the heart's really starting to contract from the bottom up, and then the sidewalls push in. And so that forms a lot of pressure to then eject the blood out. Any damage to the SA node is going to cause a resting heart rate to be wonky. People get pacemakers put in. That's where they're just replacing the SA node because it is not functioning anymore. So AP, that stands for action potential. Right, and that is the electrical impulse. And remember, one electrical impulse flows from cardiomyocyte to cardiomyocyte, from heart muscle cell to heart muscle cell. So you just really need one action potential generated, and it is going to then flow through each cardiomyocyte and depolarize that cardiomyocyte, which makes that cardiomyocyte contract. So as it flows, contraction is following in kind of a synchronous fashion as well. And so you have the SA node. To the AV node, there is a pause, a 0.1 second pause at the AV node to allow the atria to contract and push a little bit more blood. So you're going to have the atria, both of them, contract at that point. Then the wave of electrical impulse travels through the atrioventricular bundle. Then it branches. So you have branches, and you're going to have a right branch and a left branch, which then conduct the electrical impulse down the interventricular septum and up the sides and into the Purkinje fibers. So, need to know, intrinsic cardiac conduction system. Definition: a network of autorhythmic cells that initiate and distribute electrical impulses or action potentials. And remember, an action potential is then going to make the muscle cell contract. So the cardiac muscle cell contract. And contraction is called systole. So systole follows depolarization. So SA node, sinoatrial node, is your pacemaker. It sets your sinus rhythm. That is your resting heart rate. The AV node can also set a rhythm, but it is slower than the SA node. There is a delay of about 0.1 second to allow atrium contraction, which is called atrial systole. And that's going to pump blood, a little bit more blood into the ventricle. Then it goes down, and that's when the pressure starts to increase, right? And so that's going to also force the AV valve shut when you have this depolarization traveling down the AV bundle, right and left bundle branches, goes through the pathway and the Purkinje fibers. These autorhythmic cells, SA node, this is your resting heart rate. AV node can set the pace, but your cardiac output goes way down. That means less blood flow if the rate is set by the AV node. And so that really means that less oxygen is being delivered, and you have less oxygen, you produce less ATP, you can do less stuff. So people that are having their AV node set their pace need a pacemaker cell, because it's too slow of a heart rate to meet the cardiac output needs. And so people tend to be very tired and sleepy and not good. You're not getting enough blood flow. These next slides kind of go through this nodal pathway. And so I'm going to flip through this quickly, because this is really for you to study, right? It's going to the bundle of His, or bundle branches. The AV bundle is now called, used to be called the bundle of His, and then up the Purkinje fibers. And the ionic basis of electrical activity in the heart, there's actually more phases. It's different than the nervous system action potential. Phase 0, you have a really high permeability to sodium, right? So 0, you're getting big depolarization. Phase 1, the permeability of sodium slows down, but phase 2, you are now increasing permeability to calcium, which kind of keeps it depolarized here. It doesn't really, because now you're increasing potassium leaving, which is repolarization. And so now you have potassium leaving. But here, since you have calcium coming in, it's keeping it from repolarizing. This is good because you really want to, actually did that wrong. This should be down. That's down. And then this goes up and that goes down. You do not want to have two action potentials on top of each other. So cardiac muscle cells have a very long absolute refractory period because of this area where there's brief repolarization, but not much, and then it plateaus and stays kind of at 0 and then comes down. So these autorhythmic cells can fully depolarize from the SA node all the way to the Purkinje fibers without being interrupted with another action potential coming on top of it. And so this pacemaker potential is just this slow depolarization, really due to the opening in the sodium channels. But you have calcium influx that kind of limits the ability, it kind of keeps it in this absolute refractory period longer. And then you can come down and repolarize all the way down, so you can then depolarize again. And so that is where calcium channels close and potassium channels open, and potassium's going to leave and bring it back down. This electrical activity, this flow of action potential going from one heart muscle cell to another muscle cell, can be picked up with electrical cardiogram or EKGs. We say EKGs, German spelled cardiac with this K. You can say ECG because we spell cardiac with a C. Same thing. EKG, ECG. These electrodes that are placed on your skin are just sensing the electrical wave going from the SA node to the AV node to the AV bundle branch to the left and right bundle branches, up the sidewalls for Purkinje fibers, and it's just following this wave of depolarization. And the wave, whether it's going up or down, is not an indication of which way the electrical impulse is flowing, because the electrodes are really placed in random areas on your, well, they're not random, but random to where your electrical flow is going. And so these electrodes are picking up on this electrical energy moving, but it's not the wave goes up, it's not an indication that the electrical impulse is going up, is what I'm trying to say. So we have a lab, we get into that a little bit more. The one thing to note though, is that the P wave is following atrium contraction follows the P wave. So the P wave is really an indication of atrial contraction. Then you have the QRS. We call this the QRS complex because it's the ventricle contraction, which follows QRS, and atrial repolarization, which is also an electrical activity, right? When it's going from positive 30 back down to negative 60, it's still electrical voltage change. And so the EKGs pick up on depolarization, but they also pick up on repolarization. And so the T wave is when the ventricles are repolarizing. And so these ECGs are picking up on this electrical depolarization moving from the SA node to the AV node, all the way to the bundle branches, Purkinje fibers, and then the repolarization as well. And so P wave is depolarization followed by atrial contraction or systole. And then the QRS, ventricular depolarization, followed by ventricular contraction or systole. And then you have ventricular repolarization, which is ventricular diastole or rest. So we use ECGs or EKGs to look at cardiac blood flow. Is the heart muscle cell actually depolarizing and contracting? Or if a heart muscle cell has died, it's not going to contract an electrical impulse. Therefore, the EKG is going to look different because you now have muscle cells which are not functioning and allowing that electrical impulse to flow from one to another. So really, a lot of times here is where we see if there's damage to the myocardium of the ventricles. And why does the ventricles matter? Well, the ventricles are really what pump your blood. So if there's damage to ventricular myocardiocytes, the heart's supposed to pump blood. And if those muscle cells don't function and contract anymore, they're also not contracting or conducting electricity, and they're not going to pump blood. So the EKG, the sign of them not conducting electricity, is a sign that they are also not contracting. So EKGs, this goes through the P wave, results from depolarization from the SA node to the AV node, and what follows is atrial contraction or systole. Then there's a pause to allow the AV valves to close, add what little blood you can from the atria down to the ventricle, and then they close. As ventricular depolarization proceeds down the interventricular septum to the apex and up the sidewalls and into the Purkinje fibers. And what's going to follow is ventricular contraction or ventricular systole, right? Where it contracts. Now everything's repolarizing and atrial diastole because it's repolarizing and it's part of that QRS complex. So you don't really see individually the atrial repolarization. T wave is ventricular repolarization, and that is an indication of ventricular diastole or filling. And so that is the T wave. All right, so going through the EKGs, we have P wave, atrial depolarization. You have the QRS complex, which is ventricular depolarization and atrial repolarization. And then you have the T wave, which is ventricular repolarization. So looking at these EKGs, and we'll do this in lab, we're just doing basic stuff. But if you go on into nursing or physician's assistant or medical school or any of those areas, you're going to get into what does the PQ interval mean? What does the QT interval mean? And what does the ST segment mean? And they're very specific in getting into kind of having an external way of looking at the heart a little bit more in depth. But these slides go through specifically P wave and then this plateau, which is that 0.1 millisecond pause, right, to it's or delay, which gives ventricles time to fill. And it's after atria contract and pump a little bit more blood into ventricle. Just tops off the ventricles. Then you have the QRS complex. Atrial repolarization is included with the ventricular depolarization. Now there's going to be the ST segment where ventricles are still depolarizing. Then you have repolarization beginning with the T wave. Ventricular repolarization is completed, and then now you're going to get another P wave, and it starts the whole process over, right? Super exciting. Looking at some ECG arrhythmias, this is what a normal ECG looks like. And I can look at this and say, okay, how many times did the heart beat in this strip here? Hopefully you said 4 heart beats or contractions. A beat is a contraction. 1 heartbeat is ventricles contracting, injecting blood. So, right? So here's 1, here's 2, here's 3, and here's 4. Now, tachycardia means you have a really, really fast, super fast heart rate. And what happens is that it's happening so fast that your heart cells aren't getting to repolarize all the way because you have another heartbeat coming immediately after. And so those T waves get a little inverted or funky. If your heart rate is too slow, so this is too fast. By the way, if your heart is contracting too many times in 1 minute, that means you're not giving it any time to fill back up with blood before it contracts again, which means that it's not pumping anything. It's just pumping, but it's not filling back up with blood. So it doesn't have any blood to pump. So too fast is bad. Bradycardia is too slow. And that's bad too, because your cardiac output goes down. Or not enough blood flow. So that's bad too, because now you're only getting 1, 2, 3 contractions in the same amount of time. Might be the same volume, but the cardiac output's going down. Now we get to the heart blocks. So there's a first, second, and third degree heart block. First degree heart block is when the AV node is slowed or diminished. And so you have an increase delay between the atria and the contraction, the atrial and ventricular contractions. And so I believe the first degree, oh, it's not showing you first degree heart block. So it's only showing you third degree. Second degree is when conduction through the AV node doesn't always occur. So you're going to lose a 1-to-1 relationship between the P wave and the QRS. So what that means is you may have a P wave before a QRS X complex, or you may not. Third degree heart block is where there's no AV node. And so the P wave becomes completely separated from the QRS. And the atria and the ventricles are contracting not together. They're just going whenever. So it's like you got a funky P wave going, and then maybe another QRS, but then so basically this is showing you like ventricles contracting, atria is contracting, ventricles. So it's not going in the correct order. And so you're not filling the ventricle up with blood and then ejecting it out. It's backwards. So you have less blood to pump out, and it becomes a problem. So that's a problem. And then ventricular fib, or we say VFib, ventricular fibrillation, is no filling or contracting. The heart muscle is just kind of flopping around. So it's not filling up with blood, and it's not ejecting that blood. So that's bad. Bad. So that's not good. There's where you have no coordination and death is going to ensue, gonna be a problem. There's also premature atrial contraction, which is a PAC, and you can have a premature ventricular contraction, which is a PVC. That's where you have the atria contracting twice. It's just prematurely contracting, and then it contracts again. So you can have these extra contractions. All right, that is going to conclude part 1. Part 2, we're going to talk about the cardiac cycle.